into quality assurance, performance improvement, otherwise known as QAPI, and quality improvement, otherwise known as QI, in palliative care. If you have not already taken the pre-survey, please do so prior to reviewing the presentation. Although the survey is not graded, it will assist in determining knowledge transfer of concepts and the analysis of the framework and quality initiatives. The following are the learning objectives for this presentation. By the end of the presentation, the learner will be able to attribute 3 quality activities that can improve patient outcomes. By the end of presentation, the learner will be able to compare the differences between QI and QAPI. By the end of the presentation, using the PDSA model, the learner will outline a simple QAPI plan to address a threshold surge of a key indicator. By the end of the presentation, the learner will critique current palliative care quality interventions. What is QAPI? QAPI, otherwise known as Quality Assurance and Performance Improvement, is a relatively new concept of quality that originated from CMS, or Centers for Medicare and Medicaid Services, that allow for organizations to develop a quality program that is managed and measured. QAPI also allows clinicians to review current practices to see if they meet the standards of practice and clinical outcomes that are desired. QAPI is also a quality system that allows the organization or clinician to demonstrate evidence of quality improvement and performance improvement for review by CMS or other consumers. QAPI is a quality system that allows the organization or clinician to monitor outcomes of interventions to indicate effectiveness in all clinical, operational, and administrative functions of a palliative care organization. These derive from nursing interventions to durable medical equipment issues or even to human resource. All who interact with the organization, from employees to vendors, are considered to be part of the QAPI process. QAPI is data-driven. Data is derived from surveys, patient reports, nurse interviews, chart reviews, etc., or any evidence that can support measurable outcomes are used in the QAPI process. QAPI uses this data to look at the individual and system-wide focus of issues that pertain to that particular organization. The QA, or quality assurance part of QAPI, ensures that standards of care are being met through regulation or regulatory bodies such as CMS, Medicaid, or state and local organizations that oversee healthcare. What is QI, or quality improvement? Quality improvement is a continuous improvement process. QA is required and normally focuses on individuals or regulation, while QI is a proactive approach to improve processes and systems. Like its current counterpart, QAPI, QI utilizes data and uses measurable outcomes as a part of focusing care and also quality. However, QI is not part of the current regulation scheme and is also not required. QAPI is the marriage of QI and QA. In order to review, please match the correct distinctions of QA and QI from column 1 to column 2. Your score will be presented on the next slide. The need for a continuous review of systems was noted by regulatory and accrediting bodies. Bookbinder 2010 describes the process of QI, but is really describing QAPI as it relates to meeting not only organizational standards of quality, but also regulatory standards of care for reimbursement. QAPI can shape best practice standards in your organization or practice and allows for a structured approach to issues in your client populations. Most palliative care research is devoted to cancer, according to Lorenz and Rosenfeld 2007. There is limited reference when dealing with quality of care issues in other terminal or chronic illness populations, according to Parker and Hodgkinson 2011. This disparity lends itself to the need for QAPI in institutional and also private care and public care settings. There are 8 steps in the process of QAPI that allow for performance improvement plans, or PIPs, to be developed. The first step is to identify an issue, If, for instance, we see that there is a high number of falls in our population, say at a long-term care facility, we would look at research to indicate what fall rates normally occur in our population. If the average fall rate is 3 per 100 patients per month, and our facility is experiencing a rate of 15 falls per 100 patients, there might be an issue that needs to be addressed. In order to understand the reason for falls, we must always ask why this is occurring, or what is the root cause of the problem. We would then develop a root cause analysis to determine possible contributing factors. It may be an increase in UTI reporting, for instance, or a new DME that may have been delivered that the staff does not know how to operate correctly, or it may be an individual provider or caregiver that is performing poor mechanics when transferring. All issues need to be considered and mapped out. After looking at root cause analysis and ruling out factors that are not considered, we must develop a benchmark. Since falls were recorded at 15 per month, we would consider developing an acceptable threshold. And although 0 is always a goal for falls in this population, we understand that some falls will occur in this population regardless of intervention. We will use the number of falls at 3 per month as an upper threshold for our goal for our plan. We will look at the problem and try to lower our fall rate from 15 to 3 or less falls per month in this population. The next step is to develop a performance improvement plan that is measurable, data-driven, and involves all parties that will have some effect on the issue. Since the focus of our PIP, our performance improvement plan, is falls, all clinicians, caregivers, physical therapists, patients, or any person that assists with transfers or is involved with transfers will need to be involved in the process. Once we have concluded the why by root cause analysis, we can implement an intervention. Say, for instance, after direct observation and chart review, we noticed that the majority of falls were from persons in wheelchairs who transfer from bed. A PIP might be that an educational module to all staff on safe bed to chair transfer is implemented. We would monitor progress of number of falls, either increased, decreased, or unchanged. If we find that falls drop due to the educational module and the levels stay below 3, we can then institute a system-wide educational plan for all who transfer patients to wheelchairs as part of orientation or other continuing education process. The previous example of falls is a retrospective approach to quality, but there are other prospective preventative approaches that allow for QAPI and the QAPI process to address issues before they become issues. One such model is a focused PDSA, or Plan, Do, Study, Act model. This model allows for rapid response to issues, or can be used as a vehicle for proactively addressing components of quality. There are 3 attributes that can assist in improving patient outcomes: monitoring, identifying, and trending. These areas allow for a proactive approach to quality outcomes for patients by creating a system-wide response to identification of issues before they become major. If an organization is committed to education as a key component to their mission or vision, for instance, and through monitoring it is noted that there is limited clinical training provided by the organization, a PIP could be developed proactively to address issues of clinical deficiency, for instance, by keeping up IV skills. This PIP will ensure that resources are devoted to this clinical area to decrease risk for infections or sentinel events causing unnecessary harm to patients. In this simple case study, we will examine a basic QAPI plan to implement change. There is a report that is delivered to your email that states that there is a slight increase in UTIs in your population. This has been an issue that was addressed a while back and seems to be controlled at the moment, but there has been an increase in patients and new staff. The recent increase may need to be monitored for possible issues. In the report, we see that the upper control limit of UTIs for this population is 5 per month per 100 patients. We recognize that there is an increase to 7 UTIs per month. How would we start a proactive QAPI process? In the case study, we would first identify an issue. Since our report states that there are 7 UTIs, we know that there is an increase of UTIs over the upper control limit that we have established for our facility. UTI slightly over the threshold limit will need to be proactively addressed to decrease incidence. This is the P, plan. Why is this occurring? So we're going to study the incidence and why this is occurring in our population. We would do a root cause analysis. Some of the components of the possible reasons for this increase may be lack of hand washing, or maybe we receive new Foley catheters that are not easily inserted. How about increased sedentary time for the patient in bed? We would then establish a goal, or the A in ACT. Our goal is to bring infections down below the upper threshold limit within 60 days. And then we would institute an intervention. We noticed that looking at new Foley catheters, they're being inserted correctly. We noticed that reported bed times is at our upper control limit for threshold and is not unnecessarily longer than any other times. So we propose an intervention of hand washing education, and we propose to monitor our clinicians and caregivers in their hand washing techniques. Once we're able to implement an intervention of education, maybe a 15-minute education or re-education staff-wide or system-wide on hand washing, we will then begin to monitor the incidence of UTIs. After 45 days, we notice that there is a decrease below the upper control limit of UTIs occurring. We then begin to implement a standardized educational process that allows for intermittent education on hand washing throughout the year. Once we notice that there is no higher incidence for 6 months, we then make an implemented change to the system and now have a regular cycle of hand washing education that goes on until there's a noticeable change in upper control limit. This will always point to a need to address issues proactively, and also may establish an outline for providing an increased standard to your clinical practice. This concludes our presentation on QAPI. I hope you are able to understand the basic components of QAPI and how it works. This important process allows for system-wide evaluation of quality and patient care. It also allows for clinicians as well as organizations to recognize deficiencies proactively and address them before they become major issues. I hope that you're able to use some of these in your practice, and also hope that you're able to implement change for better patient outcomes. Thank you.